Welcome, everyone. Welcome to the HSPN monthly webinar. It's really a pleasure to have everybody joining us today. People are signing in rapid and fast. We're just 1 minute late starting today. Really looking forward to today's conversation and from hearing from you. Hopefully we'll have good opportunities for engagement today. Please come into the chat and open the chat box. Click on the To Everyone option and tell us who you are and where you're from. Looking forward to seeing everybody's welcome here. We have Kathy Thorpe, welcome. Logan Roy, Leslie Migoch, welcome. Lori Oswald, Marsha Barnes, welcome. We have over 200 people have signed in so far, and people are signing on and letting us know. Liz Tangay from Ottawa East, Rosie from Midwest Toronto. Rosie's been doing us a favor and helping out with sharing some of the data packages that we've been sharing out across all the OHTs. Susan Wright from Home and Community Care Central. Catherine from Windsor, Essex. Welcome, Catherine. We're pleased to see people from Windsor, Essex joining us today. And we have Judy Porteous from the Ontario Osteoporosis Strategy in Grey Bruce. Welcome. And hopefully you're engaged up in the Grey Bruce brand new Ontario Health team. Marie Bartlett from Frontenac, Lennox, and Addington. That's a lot to type. I'm glad you didn't just do FLA, but it's great to see everybody. Welcome. We have a super big treat today, and I think it's going to be really a lot of fun. Keep signing in, keep letting us know who you are in the chat, and welcome. I need to start by acknowledging the land that I'm working from at the University of Toronto. And for thousands of years, it's been the traditional land of the Huron-Wendat, the Seneca and the Mississaugas of the Credit. Today, this meeting place is still home to many Indigenous people from across Turtle Island. And we're grateful, and I'm very personally grateful to have the opportunity to work on this land. You're joining us today from many parts of Ontario, from many traditional lands for thousands of years. And I welcome you to acknowledge the land that you are working from. So we're going to start with a poll, and I'm going to ask Nusrat to help by launching this poll. Have you joined us for a webinar previously? See if it's your first time or if you've been here before. Okay, we have most people in now. Whoops. This is going a little quickly for me. We see if we can end the poll and post it. We see that there are 80% of people have joined of the respondents, 185 respondents. 80% said yes. I'm going to be playing with this slideshow for a little bit. It's on a timer. But 21%, 40 people joining us for the first time. You are in for a treat today. You see the people on the screen are going to be bringing you today's stories. We've had stories from the field with OHTs sharing their knowledge previously. And today you're going to hear from us as we tell you stories from our perspective over here at the Ivory Tower. This is the team, the broad evaluation team that's supporting this work. And you'll see there are many of us working in the background with the data, with the analysis all the way. We are going to rotate today's discussion a little bit around the 8 building blocks of the ministry. Whoops, this is going to be a problem for me. So this will be our framing for today's conversation. You know about the 8 building blocks. There are different components to each of them. We're going to focus today's conversation on what we call the middle building blocks, the middle ground building blocks. As we talk about the OHTs, we thought to try and talk about all 8, but we realized there just wasn't going to be time to cover them. And so we're going to focus on these middle ones: patient partnership and engagement, patient care and experience, digital health, and leadership, accountability, and governance, not necessarily in that order. And just share a little bit about our experience and what we've been observing across teams in the Ontario Health team space and world. And I think that we are just going to touch on each of these. There is so much going on in the world of OHTs. And even within the teams we've been observing, there are many, many activities and many advancements happening across all of the OHTs. And we're just going to drop in little snippets today of observations that we've seen and that we consider sort of exemplary in the sense that we think it's happening widely across OHTs. Not everybody is at the same place, and people are advancing in different ways and building on different strengths. And we're going to just drop in and say how each team might be focused on a different area and how they're advancing in these 4 middle ground building blocks. I'm going to turn it over to Kaylee to start off with a little bit of how we've been doing our observations and where some of our information is coming from today. And then we'll come back and dive right into it. Over to you, Kaylee.
Hi, everyone. Welcome. So I'm just going to talk a little bit about developmental evaluation, which is the approach we took. And so I'll say, well, a lot of people think about evaluation. They often think of that sort of judgment-based assessment, but that is not at all what we were doing in this. We were really looking at trying an interest in learning and supporting. So on this slide, it just covers what our purpose was, which was, again, really to understand the development of the OHTs, track and monitor the adjustments and changes to the model, and also to provide feedback to support innovation and development. Well, it's a slippery slide. So our approach was really attuned to sort of this system dynamics, complex environment, and kind of really just acknowledging the shifting context that OHTs are working in and sort of including that in our understanding. Also, we wanted to be flexible. So a lot of our work was tailored to the particular OHTs we were working with, and sort of just a comment that, the measures of success will often change as the OHT develops. So as we have a new understanding of success, we want to take that into account in our approach. And then from sort of an outcome perspective, or ultimately, we were looking at getting a better understanding of approaches to patient-centered integrated care, and then also to make recommendations for adjustments to the model. So on the next slide, I think these got reversed too. So this is just what we use for data collection. So primarily we did some observations, so sitting in on OHT meetings at different levels. We did some interviews, so a set of sort of some baseline interviews and for some also a set of follow-up interviews. We did a reflective activity or journaling where some OHT members responded to 2 prompts on a approximately bi-monthly basis. And we also did some document analysis and relied on some of our surveys and quantitative data that we've done as well. So a real mix there. So on the next slide, it just highlights our selection criteria. So we worked closely with 6 different OHTs. And our criteria for selection included geography. So we wanted a good representation across the province. So having remote, rural, suburban, urban, and smaller urban non-GTA. We also looked at the data that we had already. So some quantitative data from our Organizing for Ontario Health Team survey, and wanted to make sure that we were including people that had some higher rated performance in some of the domains, and those domains include sort of team climate or readiness for change. I'm also looking at some document analysis of the initial applications, and of course they needed to be willing to work with us. So consent to the data collection we were doing with, and it did take some time on their part. So we appreciate their involvement. So next slide just highlights a little bit about the analysis. So taking the different data collection and incorporating it with the evidence base, and also having the opportunity to compare across cases. The shared interpretation with the cases was an important part. So we also had a number of feedback points. Again, this was tailored to the different OHTs that we were working with. But in some cases, it looked like some informal touch points with the OHTs, as well as a formal report and providing data back. So a different mix of feedback that we did with the OHTs. And then next slide. Oh. So this just highlights some of the things that we were looking with. So we can see the 8 building blocks there, but also within that, we relied on the CCIC framework, which is the context and capabilities for integrated care. So for example, you can see in patient partnership and community engagement number 3, we were looking at shared vision, team climate resources. So a number of sort of subcomponents that did fit within these building blocks. So that was a bit of our approach. And I believe I'll turn it back over to you, Walter.
Okay, thanks very much, Kaylee. And I am just going to say that, today we're really talking about sharing examples of what progress looks like in those in 4 of the building blocks, as I'd mentioned earlier, and discuss some of the enablers and challenges faced by OHTs in this world, and really creating an opportunity to reflect on your progress and sharing across OHTs using the chat where you've been working in this area and some of the ways that you've been able to advance your teams, your OHTs, in each of the areas that we're going to talk about today. It's easy to assume that everyone works from a common vision, but sometimes that's not the case. Sometimes actually there's quite a bit of work that has to happen in that space, as an example, in order to bring people along. And yet other times people land on the place right away and they can go ahead and hit the road running. And so I'm just going to say that we're going to talk about OHTs from wherever they're at today, and you'll see different ways that OHTs have advanced in different aspects of their development. And so with that, I'm going to start us off, I think, with patient, caregiver, and family partnership. And I believe that we're going to have Gaia to introduce this, and then some of us will give some of our examples. So over to you, Gaia.
Thank you, Walter. Hi, everyone. So we have a couple of people speaking to each of these building blocks. Feel free to comment or ask questions in the chat as we speak, and we'll circle back to them at the end of each block. So patient partnership and community engagement. Well, this is a building block that focuses on the importance of centering patient and community partnership and engagement when building an OHT, essentially. So not only must OHTs be driven by patient needs, but they must also be co-designed with patients, families, caregivers, and really the wider community. So at the end of its first year, OHTs were expected to have a well-defined patient engagement strategy or framework in place. So patients, family members, or caregivers were expected to be members of the governance structure, for instance. A community engagement plan was supposed to be in place, and then at maturity, teams will be expected to uphold engagement in co-design principles, as well as meaningfully engage patients, families, and communities across the board. So how does one get there? Well, it included doing things like having responsive patient relation structures for dealing with complaints, developing a patient declaration of values, ensuring Indigenous people were engaged, providing training and feedback at all levels, for instance, cultural sensitivity training, ensuring patient partners were co-designing programs and services, and maybe sitting on key working groups and advisory councils. So yeah, a range of things like this. But just to see how it works on the ground, perhaps we can go first to Walter and then to Kaylee. So Walter, I wonder if you could perhaps talk to us about what this looked like on the ground when it was being done well, perhaps.
Yeah, I'd be really pleased, Gaia, thanks. And I think it's quite amazing to see how patients, families, and caregivers are increasingly involved in designing the OHT model of care and ensuring that OHTs, and I like this, there's these words from Julia Abelson, to reflect the values and priorities of their intended beneficiaries. And this is really a cultural shift that's been evolving, I'd say, over the past decade or longer in hospitals and community organizations. But the centrality of the voice has never been as explicit as we're seeing in OHTs. And so the very first thing I'd say that when we observe a strong partnership, we see patients, families, and caregivers are well represented in the leadership level, in the leadership group, generally with more than one representative. There, they're given explicit voice and an equal stature as the other leadership group members. The second thing is that patients are given the pen, for example, in setting out the patient engagement strategy. There, it's not only about consultation or involvement, but really empowerment to make decisions about how that engagement strategy should look and how it will be brought to life. A third observation is that patients have representation and voice in all key committees, and that can include primary care councils, digital health, and any population-specific working groups, such as for mental health or frail older adults, et cetera. And a final observation is that there be a central committee for the patient, family, and caregiver representatives to gather and discuss their work and their involvement in the OHT, and really to gain support from each other. So, those observations are all also key enablers and supports that are necessary for patient, family, and caregiver partnership. But so structurally, we're really seeing that we're trying to ensure representation. And from a process perspective, enabling voice. This requires, enabling mechanisms such as the acceptance and recognition of the importance of patient, family, and caregiver voices across all members in the OHT. And it also requires tactical supports, such as like identified individuals to support the patients, a staff member whose job it is to support patients and family by doing things like recording discussions, developing materials like PowerPoint presentations or other documents based on the advice of patients. For example, the patient family engagement plan, and then supporting with agendas and minutes. I also want to just mention, I don't know how many people are making avail of this, but Julia Abelson's work in the McMaster Public and Patient Engagement Collaborative, I'm going to put a link in the chat. It also has some good supports, I think, and they've been supporting OHTs across the board. And that's also, I think, a useful enabler. So that's what I've been seeing. Okay.
Thanks, Will. There are lots of helpful stuff in there, and it certainly lines up with some of the things I've been observing as well. And I think that goes for all of us across the board. Kaylee, I wonder if you could, do your observations line up with Walter's? And, it would be helpful if you could perhaps talk about some of the challenges that you've seen people encountering in this work.
Sure, yeah, I would definitely echo Walter's comments in terms of the importance of resources, or that staff resources, to support the patient family partners and their engagement. So these resources, I think, in addition to sort of that culture of openness and listening, really shows that patient engagement is a priority for the OHT and not an afterthought. And I think really important for those people who are participating. I think another potential enabler is sort of the link between the PFAC and the broader community engagement. So Walter mentioned sort of holding the pen, but I think it's also worth thinking about how the feedback from other community engagement can be leveraged by the patient council. In terms of challenges, I'd say there's a few there. I'd say the most substantive centers around the issue of burnout. So, patient, family, and caregiver partners often have caregiver or self-management duties, and that's layered onto the fast pace of the OHT. So even without that, OHTs are moving fast, and that includes sort of responding to multiple funding opportunities. So these volunteers can be stretched thin at times. So I think a mitigating factor for that would be to put the effort into recruitment and getting a sizable group of patients, families, and caregivers that can be drawn upon. Also thinking about a succession plan. So not just engagement now, but what is it going to look like in the future, and ensuring the sustainability of the engagement. So a couple of points there. I'll bring up one more challenge, and it's related to recruiting as well, and that's getting representative PFAC members. So thinking about the diversity of who's at the table, and in particular, including demographics, but also in terms of the roles and experiences. And I'll note that a lot of patient family caregivers often, like all of us, wear multiple hats, and sometimes are current or former healthcare providers as well. And we really want to make sure that we're learning from health system users on this.
Thank you, Kaylee. Yeah, again, familiar challenges, right? The issue of diversity has come up from time to time for me as well. So essentially the thinness of the line between healthcare professionals and patients, when patients and family members are often retired versions of healthcare providers. Thanks for that. Ruth has been monitoring the chat for us. Ruth, is there any interesting nuggets from the chat?
Well, we haven't seen any interesting nuggets, so maybe we need to post a thoughtful question and see if we can get some dialogue going. And we have some questions to prompt the audience.
Okay, so here we go. What has helped you? Whoops, you know, that's a little bit fast for me. Let's come back here. What has helped you to move ahead with patient, family, caregiver engagement in your OHT, or maybe some of the challenges? Let's keep an eye out for the chat here and see what people have to say. Maybe we'll go to a poll and while people type in that chat. So here's going to be our polling question, and let's get ready with the next one. And some chat is starting to roll in here. So if we could post this, patient partners being at the table, how far are you along? Patient partners are consulted and feel valued. Patient partners and community leaders are helping to identify the needs, barriers, and to co-design. Or do you have already robust and equitable mechanisms? So maybe Nusrat, you could bring up the second poll.
Some thoughts in the chat too. Having a dedicated engagement lead for sure helped us move the work forward for the patient, family, and caregiver engagement. There's also an establishment of a compensation reimbursement policy, what felt to be very helpful, and a willingness and curiosity by senior leaders to get patients and caregivers involved and really listen.
Yeah, maybe we can end this poll and share it out now. I see a number of people have responded. About a quarter of our audience has responded just over that. Wow. So, I mean, people are at all different phases here, right? And different stages in terms of their patient and family engagement. With some people ensuring people are at the table, and then many of them actually being involved. And I see that the chat is definitely coming along.
Another challenge measures the confusion with multiple initiatives and the burnout associated with that.
Yeah, and I just see there, I just saw that some of them were in the early days because they were just starting out, but many of them really advancing. And I think somebody had mentioned that it was very useful to have patients and family at the tables. And someone had posed a question about whether, just looking back here now, sometimes they go by quickly here.
Yeah.
And I just want to get the right one. And it was about when they're doing their focus populations, did they want to have a focus individual, say, for example, with their frail, older adult population? And I think that in that space, when you are trying to design care, I'm not sure that the representative at the table of that planning table needs to be absolutely representative of each focus population, because we've got a lot of populations. But the co-design of the work, the patient needs to make sure that the co-design of the actual implementation pathways, that the right patients and families that are going to be affected are part of those design groups. And so if the design is happening at that table, then I'd say absolutely for sure that it would be important that the right people. So it's wherever that design work happens, I think. And so that was, I think I found it now, Marie-José Lafontaine was asking that question. Elizabeth Tanguay highlighting again, to echo some of the challenges that we've seen is burnout and confusion with multiple initiatives and challenges. But Elizabeth also offers an opportunity to says what helped and continues to help is to allocate more time and resources to support the client partners and needing to have that dedicated community engagement resource. So talking about that dedicated resource that we've seen to be very, very helpful. And it's not easy to find the time or the resources to do this, but to do it well I think our observations have been that that's an important aspect. Ensuring Claudia de Boer identifies them being important to have reimbursement policy and be helpful to share some of those across the OHTs. And I'm not sure, I think there is a patient family community of practice, and that would probably be the excellent space, but we'd be happy to be a conduit for some of that information as well. Kaylee, you're nodding. You're aware of that group?
There are a couple, yeah. Hosted on the OHT shared space by RISE. Great resource.
Yeah, it's interesting. And some people like Susan Wright saying, working in the system and experience as a caregiver, but haven't seen the communication on how to engage in OHTs. We've also seen, I know when North York was here in the fall, they were putting out a recruitment campaign advertisement as part of the webinar. OHTs could be doing that. I think, we've seen some widespread community engagement writ large, but then we're also talking here about having people directly engaged in that planning. And so it seems there are some available volunteers. I'm not sure which OHT Susan Wright is closest to, but for the ones looking for extra resources, it seems that maybe you have an active helper there. And it seems Ashton Nicol, I'm not sure PCCP, what that acronym is, but appointing an OHT governance co-chair and seats at the governance table, which is an excellent approach, right, going ahead. Joe Padula asks, here's a challenge. How do we get those who have lost trust in healthcare to become engaged in a patient and family group? I don't know if you've seen that or experienced that, but yeah, one can imagine that some patients and caregivers have lost some trust. I'll say, I remember we had Chloe Gallagher, and I would have thought if anybody had lost trust in the healthcare system, it would have been Chloe Gallagher. She's with the Burlington OHT, if I get this correct. And she's a patient family rep there. And so I guess, trust is the foundation for all of this work, and relationships are the foundation for all of this work. And it can take time to build that trust. So leaving the opening and ensuring that the people who are already at the tables are taking the time to help build that trust back up. Lots of examples here of other OHTs doing some work, and just being sure that when you're sharing it in for us to see it, you need to be sending the notes to everyone. I see Leslie McGough has put a link to the community of practice around this. So that's some great opportunities. Any last few thoughts? Did I miss anything, Ruth, in the chat there? Or?
I think you got most of them, Walter. I think Carol Ann had a question about a framework. I
think in general, Julia Abelson's work is quite helpful in this regard, and that her team. I refer to her because anytime I want to know about it, I ask her. But I will, as soon as I'm not doing this, I'll put something in the chat that's a link to their resource at McMaster.
Yeah, a consistent application of a reasonable recognition framework for patients and caregivers was the comment from Carol Ann. I don't think I'm not capable of responding to that, but.
Okay, and Wendy Wu has a nice quote in there and is getting some agreement. Defining the problem correctly before looking at the solutions. I think that's excellent advice. What is the problem we're trying to solve for? I think, we've done some work in population segmentation and some of the prioritization, and we'll come back to that, I think, in terms of suggesting populations, which might be part of what Wendy's asking there. But I think, Wendy, you've done quite a bit of work, and you were on here talking, and the importance, I think, of ensuring equitable representation across your OHT has been one of your campaigns as well. And I commend you for that, and think that that's another piece that is very important, as equity is really important to OHTs and need to be for population health, to also ensure equity and representation in the patient family groups. I think in the interest of time, because we have a lot to cover, we might move on from here. And I think I have the pleasure of introducing the next topic, which is on leadership, governance, and accountability. There, I'm going to try and make sure this window doesn't go sliding off screen on me. So some of the building blocks focus on one area of change that'll need to be replicated over and over. That would be the case, for example, for in-scope services, where services need to be designed and optimized pathways for patients with common care needs, tailored to the populations, and then that needs to be replicated for other population groups. But some of the building blocks are more foundational, and strong development will serve to support the entirety of the OHT's activities. And that's the case for this building block, which includes several components within here. If you look through what was originally set out within here, it includes small g governance, or how the OHT partners interact and share in the development of the OHT model. It extends to large G governance, or the structures and processes that are put in place to oversee the model. That's included in this building block. Also included is the engagement of physicians and other clinicians in the development of the OHT model, such that the mature state of full clinical and fiscal accountability can be achieved. And that's shown over there on the right side at maturity of what this is going to look like. Within here also includes the development of formal agreements amongst members, such as the collaborative decision-making agreements, development of a common vision and goals, and a strategic plan for the implementation of the OHT. This is a lot going on in this one block. Finally, it encompasses leadership. And in the complex world of health services, leadership here will have to be adaptive and distributed. At maturity, teams have not been given a direction on specific structural model for governance, but the direction's clear. Each team will have a single fiscal and clinical accountability framework, including appropriate financial management controls. This isn't the first thing we're going to achieve. It's going to take time to build towards that state, years in fact. And so what are some of the ways that OHTs are starting out? And so let's touch on some of the ways OHTs are advancing, keeping in mind that the examples we'll talk about now are not the only examples of development in this particular building block, or within the developmental evaluation, or further afield. There are only some examples that are worth highlighting because they demonstrate the ways that OHTs are advancing and overcoming challenges in the development of their models. We hope you'll see this as an opportunity to also share with us and all of us today in the meeting that how you're seeing progress in this building block. And we're gonna, as I said, focus a little bit on three aspects of this building block. The first one is going to be governance. The second one is going to be primary care engagement, physician engagement, particular emphasis on primary care. And then the third one will be strategic planning. So I'm gonna turn it over to, I believe Gaia is going to get us kicked off on the governance aspect. So what have you been seeing, Gaia, in the area of governance?
Well, so the OHT that I was working with really prioritized governance, right? And I think it was the first to become incorporated as a nonprofit corporation with a board of directors, and I believe it might still be the only one to do so. And I do see some of you here from this OHT, so feel free to add, correct, and contribute to the discussion in the chat. So why do this? Well, a range of reasons, it seemed, which included just the fact that, that there were some key leaders in this OHT that had quite a bit of expertise and interest in this area. And also they realized that it would allow them to handle certain things more efficiently, so things like funding, service procurement, for instance. And they also thought perhaps it would allow them to establish policies and guide decision-making more efficiently. So how did they do it? Well, it took a lot of meetings, a lot of time. So stakeholders came together in many meetings, over many consultation sessions, over many months, to essentially talk about different aspects of incorporation. What would be the purpose of this new entity, right? Who would compose it? How would it be operationalized? And there were lots of thoughtful discussions, just starting even with the philosophical implications of partitioning themselves into sectoral buckets for the sake of assigning both seats, given the inherent intersections, and given that the mandate of the OHTs was to really come together and find these intersections. So a lot of time was spent figuring out who should be represented, how to ensure equity, how to include as many different voices as possible without simultaneously having 100 different voices at the table, right? That might come in the way of getting things done. So for example, they felt strongly about the priority population they had chosen to congregate, to focus on, and this was congregate settings. And they wanted it to have a board seat. But congregate settings included everything really, from residential care facilities, long-term care, retirement homes, people experiencing homelessness. And people wondered how a sector like long-term care with very unique regulatory challenges could possibly fit in a single congregate setting board seat, right, alongside these other interests, including for-profit stakeholders in residential care facilities. But they decided that one way of addressing this issue was perhaps by emphasizing that, the person chosen to occupy the seat, it was important maybe to emphasize that they see themselves as a representative of a sector or an organization, not the representative of a sector or an organization, but rather, as sort of representing the sort of conglomeration of interests that it was encapsulated by this one seat. And it perhaps helped that theirs was a relatively mature partnership. And it wasn't that there weren't any new players at the table. In fact, this was an OHT that had been asked to incorporate a neighboring geography within its fold. But at the same time, there were long-standing, there was long-standing familiarity between some of its key players. So that really did help. They had already worked together around lint tables, around other integrated care initiatives. So that was certainly a contributing factor that helped. Walter.
Thank you very much, Gaia. And you've observed some, very structured approaches and very organized. I wonder, Ruth, I've heard you talk about some of the more challenging conversations in the evolution of governance, and sometimes arriving can take a little bit of time. I don't know. Do you want to add to this?
Yes, thanks, Walter. In my case, the emphasis here was on more the small g governance, but they're proactively working at putting their attention to the big G governance. But this leadership table, their meeting agendas routinely include about an hour set aside in that agenda to have some very generative discussions. And it allows for the ability to have some tough conversations, and voices are heard and listened to, and it enables the consensus building to be achieved. And it's highly commendable when you observe this happening. The intention to allow time for open, honest discussion and have sense-making happen among all members for the issues at hand. And this is also observed down at the working group levels. I think that when you see it at the leadership and you bring it down into the working groups, their emphasis is on intentionally building trust among the members that are representative of multi-sectors. And it allows for that continuous trust building and active movement and shared purpose in what they're doing. I think what is a key enabler is that they've prioritized cultural sensitivity in all the processes and meetings that happen. And I think because the partners at this OHT came together in ceremony, it's a very culturally strong signal when this happens. And it is remembered at each of the meetings so that people can come and keep their priorities where they need to be to get the work done. I'd have to say that a challenge, I think, that was observing that OHTs that have had partners that have worked together a long time or in previous situations, operationalizing this collaborative decision-making agreement is sometimes a challenge when you've had that context of you're very familiar with working with these people, but this collaborative decision-making, making it operational in the day-to-day workings of the OHT can sometimes be a challenge. And the other challenge that is faced is that the system, they're working in a system that sometimes works against building trust among their members. So that makes it a challenge. It makes it important to continue to foster and work on the trusting relationships when the system is not enabling that. It can create the divisiveness that we're trying to eliminate within our OHTs.
Yeah, so thanks for pointing that out. And I'll come back. I might say this a few times today. It's not an about building block, but fundamentally trust and relationships are the foundation for the OHT's work. And so that work is required in that time across all of the involvement. There are a few places in the chat. I think we're going to go ahead and then come back to the chat at the end of this section. So thanks for those reflections. And as promised, now I think we'll have a word on physician and particularly primary care engagement. And thanks to the comments in the chat, we will come back to them. So Kaylee, you've also been out observing, and we were talking about this the other day, and you thought maybe you could help summarize what you've seen.
Sure, yeah, I think this, a very important part of OHT development and something that I think OHTs have taken a different approach to, but one approach is, directly including this as a strategic goal of the OHT and making a robust structure for primary care involvement in the OHT. So this would be primary care involvement in OHT leadership, having a designated counsel, having representatives participate in the different working groups, so being very hands-on. And this allows for relationship building, better understanding of the care environments, and also can potentially support the move away from that organizational focus. In addition to that internal structure, there's also an opportunity for other formal structures like a primary care association. So one example includes over 100 family physicians within the OHT's catchment area, and really with the goal of ensuring primary care providers in the community have access to the tools. And I would say too, another piece that we're talking about engagement, but I think something that contributes to the success of the OHT is not just that, but also the leadership. So having primary care offer their leadership and championing different initiatives can contribute to the success, and particularly in this early stage, help get initiatives off the ground. I'll comment on a challenge in this area. I think it came early for many OHTs is addressing the compensation for physicians. So important that they're not losing their wages to participate. And this also, this early challenge can lead to a lack, and has in some cases, of that early involvement of physicians and primary care providers, which can be something that can be overcome. And I think some of the ways we do that is through outreach and relationship building. And I will just comment too with this, it does take time because a lot of the partners haven't necessarily worked together in the past. And so there might be some trial and error in terms of what processes work best. And again, I'll highlight that the outreach. So I've seen an example of a physician chair taking the initiative to reach out to individual providers, especially solo docs who aren't necessarily well connected to others. And then the other thing to highlight is just thinking about the needs of primary care providers and physicians. And in the early stage, that might be their information needs, and finding creative ways of meeting those. So another example was an OHT using a WhatsApp group to really keep people informed, and that was pivotal, and particularly in the early waves of the pandemic.
And I've seen also, how does the OHT's work help to solve the physician's problems in some ways? And sometimes I've seen this advance through, updates around COVID management for patients and primary care, just ways of helping to solve the physician's problems and making that part of the core work of the OHT as well. What about you, Gaia? And then maybe Ruth.
So one of the things I observed was the amount of organization that was involved and that was really required right at the get-go to pull people together, because well, this particular OHT that I was working with, it's, you know, in order for it to even have a unified voice, it needed to know how it felt, but it was difficult to do that in the absence of an organized body. So it had to kind of focus on getting organized for the first time as a collective. And the pandemic sort of acted as a trigger for this. It provided an opportunity for all of them to sort of, well, they kind of coalesced organically into these bi-weekly virtual town halls to plan the city's COVID response, and the OHT sort of leveraged this. And, you know, there've been really good strides made since then, actually. So, you know, they're actually working out governance again. So, you know, really formally coming together again. So yeah, lots of echoes to the broader stuff on governance going on here. So they're trying to figure out how to bring together physicians from these different primary care structures, right? For family health teams, community health centers, family health organizations, how to maybe include allied health and nurse practitioners involved in primary care as well. And again, you know, folks were wondering, how do we, you know, would including all these folks then affect our ability to be effective? And again, they decided, you know, perhaps we do not have to go down this Noah's Ark route of having one of each species around the table, but perhaps, you know, we just need to emphasize that everyone needs to recognize that they're not just representing their own practice, but rather all the needs of the patients in the city. And yes, one of the challenges that was encountered was I suppose the translation of what an OHT was and why it mattered to hospitalists, right? And this could be because at the beginning, there weren't really any hospitalists sitting at the OHT primary care planning tables. And so it was a little bit difficult to communicate to them, but they're trying to address this right now by perhaps thinking about, you know, developing a set of aspirational guidelines to demonstrate impact that can then be shared.
Great, thanks, Ruth. And I'm gonna have to ask you to be a little bit brief.
Okay, yeah, I'm going to be brief. So yeah, the OHTs that I've been involved with, I think it's not so much about emphasis on physician engagement per se. It's just having the primary care, non-physicians as well, right? Your nurse practitioner clinics, CHCs or Aboriginal health clinics, those partners are at the leadership table. And I think that the engagement with specific physicians is happening through the early development of these primary care councils, being informed, and as well as through some digital tools that are being rolled out across some of the primary care practices.
Great, thank you. And we will come back to the chats. And the Zoom chats don't have the option of liking, but Rosanna is getting some comments about liking on her chat. So we'll get to you and that question. The last area we wanted to touch on in this area, and like I said, it's such a big building block, is strategic planning. So thanks to both of you. I know that OHTs have been involved in strategic planning of late, many OHTs coming together and collectively having responded to COVID-19. They're now coming back to their OHT work, you know, reassessing their original plan, seeing what they need to be doing, and revisiting some of their strategic plans. I think we've seen that in a number of the OHTs that we've been spending time with. Kaylee, have you seen particular examples of strong examples of strategic planning, and what would you say is enabling those successes?
Sure, yeah, I definitely have, and something we've talked about before in webinars, but so the particular example I'm thinking of really started with a robust engagement effort, both with internal partners and also the community at large. So information from that engagement was translated into strategic goals, objectives, actions were associated with each of those. And there was ongoing, once that was established, ongoing internal engagement to really refine that, but also to make sure that the different sort of working groups or subcomponent parts of the OHT understood where they fit within that strategic plan and what that role was. And then carrying it even further and really making it a template that to be able to monitor each group's progress towards completing the objective and follow through to implementation. So a lot of work setting up what that plan was, but also carrying that forward in terms of implementation. Some key enablers, I think, support for leadership, from leadership to do this work. And again, similar to others, some resources from the backbone team and time. So it is a substantial amount of time to go through this process if you're doing it in a really engaging way, and can take several months to complete with these consultations. A quick comment on challenge is the general challenge of secondary interest. So most partners we know are used to working through an organizational lens. So I think having that robust engagement process in your strategic planning really make sure that it's representative and going to serve the patient's needs. And also then the strat plan itself will address the potential issue in keeping partners aligned.
Okay, thanks very much. Anyone have anything else to add around strategic planning? I mean, I think I've seen some of this work done as well. And now the challenge is getting the strategic plans into operational plans and the real work ahead. We have our little discussion question for this section here is to think about what has helped you move ahead in the areas of governance or primary care engagement or strategic planning, and maybe what are some of the challenges. And let me come back over to the chat where I know that there were a couple of good comments coming in. Jim is getting some support for advocating for the government to fully describe the intention and require publicly accountable boards for OHTs. If we're going to get there, we need to have a clear vision of where we're headed. I think that's what Jim is referring to, Jim Hanna. There's a question around with so much variability in governance structures or relationships, how can we ensure that the service provision isn't also variated and that we're having the same high standard and expectation of care across OHTs? I think we need to have the same vision, and the last one we're going to talk to today in terms of building blocks is around patient care and experience, and that's where we need to be laser focused. And we'll come and we'll talk more about that towards the end of this webinar today. And I think that is the common denominator across all of the OHTs. And then, we need to do many things, and OHTs need to be doing many things to get there. Sharing clinical information, having good oversight and governance, having effective distributed and adaptive leadership in order to advance those aspects and implement those tools. But with that laser vision on the outcomes, I think if we keep our focus on the quadruple aim as being a standard for the outcome and measuring against the quadruple aim, that's where we're going to want to see the standardization. Right now, the fact that OHTs are exploring different care aspects and approaching their models and their development in different ways, I don't think is a bad thing. And I think it's really the best way forward. Okay, I'm going to come down. There was a question around governance from Rosanna. Here it is. Will the HSPN be evaluating and examining variation across OHTs with respect to governance structures and a partnership decision-making process in a future report or summary? And I'm not sure, Rosanna, if you've seen, we have just finished collecting some structural information across all of the OHTs around their leadership groups in terms of that group that might be overseeing or acting in a governance role at the outset. I'll say in networked models, when we look at the literature and other examples around the world, in networked models at the initiation and the outset, it looks very much like OHTs with things like steering committees made up of members from across participating organizations. And so we're asking OHTs right now, well, we've collected information on, what is that membership like? How large is it? What is it representative of in terms of sectors? How is it selected? And how do they make decisions? And then how does that group communicate with their other organizations or their organization's governance boards per se? So we're going to be summarizing that and sharing that back out with teams. But we've also, right now, we are in the field with our survey of members of those leadership groups and asking questions about their perceptions of OHT leadership and how decision-making, how effective decision-making is, and getting that perspective. And we're going to bring those two pieces together, the factual and the perceptions, in our work coming up very, very soon. And I saw that there was another question that was related to this, and I can't see who it was, but oh, there it is. Marie-Josée Lafontaine talking about some tables having stronger and louder member voices that either mute other smaller members or marginalize input. So that is one of the specific aspects that we have in our OHT survey, the extent to which people have voice, or is that more centralized? For now, we can only ask it in the leadership group, not all the subcommittees, but at least that would be a little indicative or emblematic of what might be happening in the OHT. So we'll be coming back around this. Okay. I am going to, there's a question here, how are OHTs developing strategic plans as Ontario Health itself continues to develop theirs? I would say OHTs can't wait for OH. And in fact, I'm sure there are many people from OH today joining us and watching to see where Ontario Health teams are heading so that they can support that work. And I think if they see strong models, you'll see them using the examples of OHTs that are doing very well to advance and then to scale and spread that, that knowledge and sharing. Ashton Nicol raises a point. The challenge is about determining strategic priorities. How do partners navigate the circumstances where long-standing resource-intense relics of the system are not prioritized? So I think, I'll ask OHTs themselves, like, how are you negotiating this challenge in determining the strategic priorities and balancing the interests across the members of your OHT? What will be successful in that regard of ensuring that power is equally shared and people have an open conversation? Here at HSPN, we like to bring data to the tables and help that to inform. So we've talked about even talking about your patient population and thinking about that and having the focus on which priorities in terms of the patient populations do you need to focus on, and working from that space as opposed to the interests of organizations. And Janice Kucheru, you may be a patient out there. Patient navigation has always been a problem and has not improved. Hopefully each OHT will address this huge issue. I could not agree more. That is the benchmark standard, I think, that we need to be measuring against. How do patients feel? How well organized is their care? That's a question that's on our patient experience survey, and we think it's a question that every OHT should be asking. I think, with this in mind, we should keep heading along on our journey today and our tour. And so I am going to move us along over to our digital health. And I will put this opening slide up just so we can center our conversation around digital health. And Kaylee, I think you're going to lead us here.
Sure, yeah. So I'll just give a brief intro to this building block. So it's really about how data and digital solutions are harnessed, and not dissimilar to others, has a really strong connection to other building blocks. So early markers and progress in this area will be harmonized information management plan, increased adoption of digital health tools, and plans to integrate services and use data. At maturity, and I'll read this, teams should use digital health solutions to support effective healthcare delivery, ongoing quality of performance improvement, and better patient experience. So very succinct there, but there is a lot that's going into that. And so thinking this includes work on data privacy, security, includes work on patient, provider, system-oriented tools, so at those different levels, and also includes data sharing for the use of patient care, for the use of sort of learning and improvement, as well as population health planning and other uses. So again, a lot is packed into those two words for this building block. So it'd be great to hear some examples from the field. And Ruth, I think we'll start off with you if you have if you want to share some of your observations related to this.
Thanks, Kaylee. Yes, so one of the OHTs I've been involved with has really invested a lot of effort into this particular building block, enabling start my video. Sorry, I didn't realize I was. Just gotta get my setting. Anyway, so seeking, they put a lot of energy into this digital building block, enabling sharing of patient data between primary care and hospital, that transition, and also focusing their attention on those funding proposals that really were laser focused on digital, so that they could get into remote care monitoring that would support their priority populations. And they also prioritize decision support, investing in that and human resources and technological resources like the healthcare HPG software to allow that sharing between primary care and hospital care. So that promotes this enhanced digital data sharing capacity. Also, the enabler was that they recognized that these were longstanding struggles that they had, and this was a definite priority for that OHT. And they quickly mobilized with the digital working group and acted upon it. I'd say the challenge that was faced for this particular case is that the lack of a stable backbone throughout the process might have slowed things down. Despite that, they've done really great work to have a good platform to begin their data sharing, information sharing for providers, as well as decision support tools to inform how they're going to proceed in modifying their care plans.
Thanks. So another challenge that that we've talked about is sort of that with so many different potential work streams happening with digital health, that there can be a challenge in communicating it within the OHT. Guy, I'm wondering if you could speak to how this might be addressed in OHT from your observations.
Sure. So yes, communication was an issue, as I imagine it must be across so many OHTs, right? So, but there was an early recognition of the difficulty of communication in the digital arena. So not only did systems not talk to each other, but also folks didn't know what other partners were doing, right? So there was little sense of what was being done collectively. So meetings, first and foremost, became a way of sort of informally sharing this knowledge. So it was a space where partners could come together and present on the various digital initiatives that they were individually working on in their various organizations. And also, people decided that before they actually started transforming things in the IT space, it might be a good idea to actually sort of formally establish what already existed, right? So figure out what we already have and perhaps share to some extent. So this OHT said about mapping existing digital assets, so everything from data repositories to navigation services across partners. And at the same time, they decided to apply for as many pots of relevant funding as possible. And they actually did this very well. So they developed well-structured guidelines to provide a meaningful way of reviewing and coordinating funding opportunities. So when a funding opportunity was announced, it would be shared to gauge interest, and then they would organize working groups and drop-in sessions for each one. So the constellation of people working on each of these funding opportunities would also then have to show that they had clinical and executive backing, right? That they met financial requirements and that it was aligned with OHT priorities to move forward. And it would be presented back to the larger group. And certainly much of this work was made possible with the help of a dedicated staff member, right? So really important resource.
Great, thanks. For those OHTs out there, I'm wondering if in the chat, if you want to share some of the things that's helped you along with your digital health efforts or potential challenges.
Yeah, and I see Nashaba's definitely put out a challenge, well articulated about the notion of sharing clinical and utilization data across all healthcare providers is a critical both to transitions and information continuity, and also reducing the burden on people to share their stories. It can be a costly building block. And what are some of the ways to leverage provincial funding to share resources? So I might ask OHTs that are participating today, are there ways that you are leveraging provincial funding? Particularly there's some digital asset funding I know that's come up. And some teams I've seen to do things like use that money for advancing on models like e-referrals and e-consult, which includes some portion of information sharing. So I think I'd be interested to know if other people are finding creative ways to use those funds in those ways. But I think that finding ways to share clinical information in the short run, there's probably workarounds that can be made by just linking together one or two pieces of information at a time. So maybe giving a certain set of providers access to physician EMRs or physicians access to something like a CRIS data system. But ultimately, I think we need to find ways consistently for OHTs not to all use the same information, but to be able to have a standard to plug in to each other. And I'll strongly encourage my colleagues at Ontario Health to help with that support for across Ontario. Amber has identified that we've been quite disciplined to only apply for digital health funding that enables and advances progress of our priorities, identified via co-design and having a decision-making tool to support that process. I think a little bit, Gaia, that refers to some of the ways that you were talking. Leslie raises the issue of been difficult to commit new digital solutions that might meet our needs without ongoing funding to be able to sustain them. Sustainable funding for OHTs will have to be front and center for the next government. This is not project work that can be done in periodic pieces. There needs to be a commitment. And I think many of us today are sitting here without clear funding beyond March 31st. And that's a little late in the game when it's March 20th. So I understand that's a challenge out there. And right now there's got to be a lot of faith in the model and a faith in government and trust to enable this work to continue. And I think that's the stand that we're at right now. And hopefully there will also be new opportunities in the near future. Helen Johnson asking if there are any teams from the hip and knee bundled care teams that have found ways to share clinical records across providers. I think that's an excellent example of having, and I know that I was involved in the evaluation of integrated funding models, which preceded the hip and knee bundles. It was an exemplary bundle care or pilot, one might say, where we did see clinical information passing from the hospital into community care, and in some cases for primary care to also be linked in. So it's quite possible. So that's some of the key pieces coming in here. And Nash will be getting some kudos for that comment and people agreeing out there. And I agree with Wendy Jerry here that says, not entirely reinventing the wheel, seeing what we can do. There are going to have to be clear standards, though, for how these systems link in a way that is accessible directly to Ontario Health teams. And the other piece that we need to be very cognizant of is from a patient's perspective. Patients all receive care from the primary care providers that have been linked to the Ontario Health teams, but they receive care from many different other providers across Ontario Health teams. And the more we can enable consistent data sharing across those different providers, I think that will be important. I have to move on. We're going to go to our last section right now, which is in the space. So keep the chat going with your comments and suggestions, but I don't want to lose the opportunity to talk about some of the most important aspects. And this is one, patient care and experience. And so, I'll say things starting out, ultimately, this is what the OHTs are all about. And the purpose is really to redesign the health system to enable population health management and integrated care optimizing the experience for all individuals who require health and care and getting ahead. We also need to be getting ahead and going upstream to improve the health of the population. And so we're going to end off today's tour of a few of the building blocks with a focus on patient care and experience. Year one expectations here include that care is redesigned and access transitions and coordination and integration has improved, to the earlier patient comment about whether it has or not yet, and that for priority populations, there are zero cold handoffs. At maturity, the ambitions are high, as they should be. The teams offer patients, families, and caregivers the highest quality care and best experience possible, following the quadruple aim. And we encourage every OHT to focus on how their work translates to improved health outcomes and experience. I think that's the common denominator that enables fair discussions across the partners. We encourage OHTs to think about how future patients will describe their care differently than they would today. So we'll introduce here 2 patient stories today and talk a little bit about how these improvements were enabled by the activities of their OHT providers. And as we describe in an early guidance document for OHTs, how can patients and caregivers needs be met by providers and managers? I'll put a link in the chat. We look for front stage patient-facing experience, and we'll also talk about the backstage organizational activities that need to be done to support optimal patient experience. Ruth, I think we might start with you on this.
Yes, thanks, Walter. Yeah, so it's really great to have the opportunity to describe in the patient's words what the OHT has done for that, like the impact of the OHT. This letter is from a patient who experienced an interaction through a resource that was funded through the OHT. This person had moved to the area and had surgery, but didn't have a primary care physician. The patient happened to be living next door to one of the PFAC members who informed them of the OHT and what this resource of a nurse practitioner that was purchased for the filling the gap in the OHT for lack of primary care. And this patient talks about that if it hadn't been for this introduction and care by this nurse practitioner, I'm sure my mental health would have deteriorated and I would have ended up in the emergency department. I had surgery, my wounds needed to be attended, and I had nobody to turn to. This letter is to say that this nurse practitioner enabled my recovery of my mental health, and it would not have proceeded as well as it is, and making me feel as well as I am now. In summary, I feel that this nurse practitioner is an invaluable asset and therefore reduce the stress on our hospital as well. So I think this is a really nice early example of what the OHTs have been able to do to improve the experience. This person had an easy transition. They had care coordinated that they needed for their post-operative care, and there was a zero cold handoff, and the patient had a good experience.
Yeah, and so there was like warm handoffs there for sure, right? And I think that was really an important aspect of being advancing there. Kaylee, what about from your view? I think you've also have another.
Sure, yeah. I have there's an OHT that has developed a seniors home support program, and this was launched in 2021. And is an integrated program for home-bound seniors and delivering their primary care. So it really does take multiple sectors and partners working together. So some providers include primary care physician, nurse practitioner, occupational therapist, pharmacist, etc., and all using a single EMR. And within the first few months of this program, there were 23 new patients enrolled. So this is sort of where the program that the patient quote that I'll read from came from. And I'll say this is from Eastern Region North Durham that does have a patient story video on their website. So I do recommend checking it out because it's a great video. But this, just a highlight of this particular patient story, we hear that she was not able to access home-based service. And she really participated because she was used to doing things on her own. And she shares some praise for the care providers and the staff, but also just the quote on the impact on her was, by participating in the program, I now have a reason to live, but I didn't feel that way before. I felt alone and trapped, especially during COVID. I now have healthcare services provided to me that are personalized when I need them, and I can relax knowing it takes the pressure off the hospital. So many patients who need emergency care receive it. So I think a really a good example of a really strong impact of an integrated care program. I can comment quickly on the sort of enablers of making that happen, and you know, launching this program. Again, it's connected to what we've talked about before in terms of resources and backbone support. So in particular, having really strong project management from an early stage to be able to launch this, and also again, what we talked about before, the engagement of primary care in the initiatives and taking a role there. I know that for some, you know, on the other side of the coin, this information sharing and backbone resourcing can also be a challenge for others. So, you know, I think in particular, as people are stretched with pandemic responses, there is that challenge, but really nice that that this program was launched and that it's already having an impact on patients.
Great, thanks. And I'm going to correct that note that I just put in the chat. I tried to put the link and I think I just got the actual quote. So I'm just going to finish up with that little bit there. I'm just wondering, you know, for folks, Marie-Josée Lafontaine, she says, yes, you know, starting within our organization and focusing on expanding the scope and resources to assist with education and navigation, more work, but it's working and it's meaningful. And I think that that's really important, that we keep this focus on the patients and caregivers. And I recommend, I put the link into the patient story that Kaylee was referring to. It's online and we were hoping to play it, but I think we're a little tight on time. So I recommend that everybody go and have a listen to the ways that OHTs, by redesigning care and thinking about the needs of their patients, can work together. And, you know, this isn't totally new. The health system has been looking to make improvements for care across providers. The OHT, I think, gives it a focus and a real way of choosing which priorities all of the OHT membership can focus on and deciding who needs to be at the table. So bringing those partners to the table at first, and then selecting priorities and working to advance care that really impacts on the patient experience. I think I'm gonna have to close off the tour of the building blocks now and just get around to a couple of concluding remarks. And I'm gonna go around to each of us in a minute. And I'll just highlight though that, you know, if we've heard anything today, it's that OHTs are not uniformly progressing down the same path to maturity. In fact, I think it's abundantly clear, probably the most central finding of our developmental evaluation is that there is not a single path that we should lead all OHTs down in rapid succession. Why? Well, healthcare is inherently local and OHTs are built upon relationships, partnerships, and trust. And these relationships and partners have varied histories across Ontario with varied strengths based on the foundation of work teams prior to becoming an OHT and after having been approved as OHT candidates. I think OHTs are, as they should, developing from their areas of strength in order to build momentum towards this new way of organizing and delivering care. And eventually all OHTs will need to achieve maturity across all the building blocks, but the complete, exact, and specific staging of this work should not be uniquely prescribed. I think that's our first key finding. A second key finding is that the building blocks as configured at this time are at best really important guidance posts. And I'll say at worst a bit of a mishmash in different strategies that should be pursued to advance the OHT model. And breaking down the building blocks into components or sub-elements, I think is a really useful approach to genuinely identify progress. It'd be difficult to say that all OHTs are progressing on everything that is in the component of leadership, governance, and accountability. But in different aspects within there, we've talked today a little bit about some governance, some strategic planning, some physician engagement, primary care. And those are all areas And so I think that way we've approached today's webinar in unpacking the black box of maturity, at least that's from our perspective and view from atop the Ivory Tower. So I'll just turn it over now. Kaylee, concluding comments.
Sure. I think there's lots of lessons learned, but I might just draw attention to, I think that the relationship building, the team dynamics, and making space to reflect on your processes as well as your performance is going to be an ongoing endeavor with OHTs. So again, making space for reflecting, making space for learning and dialogue. So even with the teams that had well-established working relationships and trust prior to initiating, it's still something that they're going to have to work on throughout and will be ongoing.
Great, thanks, Kaya.
I might focus on vision a little bit and maybe translating it into practice. So, OHTs perhaps need to really put some upfront work into really figuring out what their broad vision is, because it's really what's going to guide what's done subsequently, right? So whether that's explicitly focusing on equity or provider experience or whatever it is, you will all be doing a little bit of this, but I'm talking about, sort of an explicit focus. And following from that, priority populations need to be really meaningful, for each OHT. And it's important, I think, that these priorities are locally relevant. So that's an easy way to be meaningful, right? So ideally, they bring a tear to your eye at some point, or because you feel so deeply about the need that you're filling. So, but obviously, this can cause tension sometimes, particularly if what is locally relevant to you isn't necessarily perfectly in line with what emerges as provincial priorities. So there might be work that needs to be done to balance your local needs with, or maybe creatively honing them into provincial priorities. So it's really, it's really about responding to local need, which is a great driver of enthusiasm, but at the same time, keeping an eye on how one then gets to spread these potentially, narrowly focused approaches and eventually getting to population health management.
Thanks, Ruth.
Well, I would have to say it's important for OHTs to allow time for sense making. That's the willingness to learn and use data to drive their decision making, and create safe spaces for all your members' voices as they implement this transformational change in how we plan, manage, and deliver healthcare, to strive for that quadruple aim and always keeping an equity lens. And secondly, that it's important to translate and communicate the OHT vision within and across the various levels, like the working groups within your OHT. And in order to do this, these activities require a strong backbone, project and change management support to be successful.
Yeah, thanks to all of you. I hold the mic, so I get the last word here. And I'm just going to say, from my perspective, I think that for OHTs to become the backbone of local health systems, they really need to be recognized as a thing, a real partnership and network that link all the providers who share care for patients, family, and caregivers within that network. There needs to be sound organizational structures that suit the purpose of engaging in population health management, including improving access and outcomes for the most vulnerable, enabling patients to be engaged in health promoting behaviors and activities, and delivering integrated care models and pathways of care for individuals with complex health needs. Critically, the network has to be drawn together by a shared vision of health and healthcare for their shared population. They need to have each other's backs. And so, I honor all of you who are working tremendously hard across Ontario to advance the OHT model. And I hope that some of these reflections will help you feel confident in your work, inspired by others and yourselves, and you'll continue to do this work in spite of the innumerable challenges that we could list and enumerate right now. And to our friends in the North, I believe that there's an upcoming tour to see what offerings there are in the North for Ontario health teams in the coming weeks. And I truly hope I'll be able to join in some of those, and some of our team might be able to be well represented in that group. thanks to everybody for joining us today. Just to remind people, we have this webinar every month on the 4th Tuesday of the month from 12 to 1:30. Upcoming topics, we'll still be working on our series in population health management and more examples of segmentation, perhaps understanding some chronic disease management, upcoming later in the year. Today, we were talked about early learnings from OHTs. We're going to be taking a little tour of the quadruple aim, a walk around the quadruple aim framework, and talk about measurement in each of those quadrants for Ontario health teams. And the Ontario Health Team survey, if you've been invited to join and respond to that survey, please do. It only takes about 15 minutes. We're watching the times. No one has taken more than 17 minutes yet to answer that survey. And so please do so if you've been invited. It is a closed list. It's not completely open. We're tracking the response rates on that particular survey. We'll be back to report and share the findings with OHTs individually, but then definitely with our entire audience here today. Please stay in touch, watch our website. We're always advancing it. Thank you to my co-hosts today, Kaylee, Gaia, Ruth, and to our support. Alana's in the background and Nusrat as well. Have a great day, everybody. Take good care.